Yeah.
Good morning. This is the T32 seminar of the University of Colorado School of Medicine, Otolaryngology, Head and Neck Surgery Department. We are really pleased to have today Dr. Gabrielle Ryan Merchant. She graduated in 2009 from Smith College and also in 2014 from Harvard MIT Division of Health Sciences and Technology with her PhD, having as mentors Drs. Heidi Nakajima, John Rosowski, and Somil Merchant, very well-known luminaries. And then she had her audiology degree in 2018 from University of Massachusetts Amherst. She's been in Boys Town National Research Hospital, Omaha, Nebraska since 2017, and at present holds the titles of Scientist 3 and Director, Translational Auditory Physiology, and Perception Laboratory. She has won this year the Early Career Researcher Award from the American Auditory Society. Congrats, Gabby. And then holds 3 patents, is a well-known speaker in the international circuit, has multiple publications, and I know her as a mentor in the Commend Network for Otitis Media Researchers. She now has 3 active grants as PI, including 1 from the Department of Defense and 2 R01s, 1 on auditory dysfunction for Down syndrome kids that she works on with the Linda Cernick Institute here on campus. So take it away, Gabby. Thank you for giving your talk.
Thanks so much for the nice introduction, Reggie. Hopefully you guys can hear me. I'm sorry I couldn't be there in person. I do get to visit the Anschutz campus quite regularly because of one of the grants that we have collaborating with Joaquin Espinoza and the Linda Cernick Institute for Down syndrome. So I'm quite familiar with the campus and enjoy visiting. It worked out with the timing of this series. But I'm excited for the opportunity to share the other work that we've been doing in my lab, focusing on really how we improve the diagnosis of the hearing loss that's associated with otitis media, usually otitis media with a fusion in children. So as Reggie mentioned, I am an audiologist and a hearing scientist. I am not an otolaryngologist, but this definitely has a heavy otolaryngology emphasis, this work. There is an ENT that I collaborate with very closely who works in the lab, Rick Tempero. And he's definitely a really key component of this work because of that heavy otolaryngology emphasis. So hopefully some of this will be helpful to all of you as you go through your training. So this body of work was really elicited out of an experience I had during my clinical audiology training. So I was working as an audiologist on a pediatric ENT clinic, and I saw 3 children back to back in clinic that sort of gave me some pause. So the first kiddo came in, they were like 4 years old, so pretty easy to test, relatively speaking. And we looked in their ear, grossly normal otoscopy. As an audiologist, I'm not doing anything too specific. I want to know if there's too much wax in there for me to put a probe in, or if I see any like drainage or, very clear signs of infection or something, but looked pretty normal. I did a tympanogram. I'm assuming some general understanding of sort of these very common audiologic tests, but feel free to stop me if there's anything that most of you are unfamiliar with. But this is just a measure of a very traditional measure of middle ear mobility that we do in clinic. And what we found was that it was a very flat tracing, which suggests that when we try to move the eardrum, it's not moving, which is often consistent with fluid behind that eardrum. And then we did a behavioral audiogram. And again, because this child was a bit older, we were able to get some good information. And we saw what appeared to be a moderate conductive hearing loss. So quite a bit of hearing loss, which is not uncommon. Kids have fluid in their ears. Another child came in immediately after, same general presentation. So that grossly normal otoscopy, flat tympanogram. But when we did behavioral testing, we didn't get quite as much information. They were a bit younger. So I think they were like 30 months old, but we got some air conduction thresholds that were all kind of in that normal or near normal range. So I'm already having some pause here. I'm like, well, why is this presentation look pretty identical to the first one, but the hearing losses are so different? And then a third child came in who was 19 months old, same presentation. We tried to condition them to do behavioral testing and we got absolutely nothing. Couldn't get anything in the sound field, definitely couldn't get anything ear specific. So now I'm like, well, really, even though this child has a flat tymp and, that first child had a lot of hearing loss, that second child didn't have a lot of hearing loss. And so we really don't have any idea in this scenario how this third child is hearing because we weren't able to condition them to behavioral audiometry. So the question then was, does this child have a hearing loss? Do they not? And does it matter? Do we need to consider that in terms of their management? So this sort of experience led to me digging into the literature and sort of developing a series of questions that we've been working for the last several years in the lab to answer. And so a lot of this rests on the fact that we have this thing, otitis media, that really is a very heterogeneous condition. So there's tons of variability in many forms. There's lots of different names for it in the literature too, with some sort of definitions of what's what. I think a lot of people sort of lump it into acute otitis media, where there's that active inflammatory state, and otitis media with effusion, where there's that kind of persistent non-infected fluid, but also some obviously nuance and variability even surrounding that. And then within those categories, there's additional variability. So even within otitis media with effusion, there's a lot of variability in how much hearing loss there is, how much effusion is there, the viscosity of the effusion, how long it persists, et cetera. And we really have pretty limited knowledge in the field of how all these variables are related and may impact things like prognosis, resolution, and hearing loss. And therefore, we are also sort of limited in what we understand about which of these variables may or may not be important to consider for management. So are there some of these variables that could help us predict prognosis? Like, is this an effusion that's going to spontaneous resolve, or is it going to persist and you're going to need tubes? Is this a hearing loss that could lead to some downstream effects on things like binaural processing? And so these are the types of questions and things we've been sort of trying to disentangle over the last few years. So the data that I'm going to share with you today are primarily from children who have been recruited from our otolaryngology clinics. These are children who have been diagnosed by an otolaryngologist with otitis media with effusion and are, for the vast majority of these cases, scheduled to have tubes placed. The average age of the participants in this kind of set of data is around 34 months of age, so pretty typical for that kind of classic age range for otitis media with effusion. And for the majority of the cases I'm going to show you, these are kiddos that came in immediately prior to their tube placement. So we usually see them the night before or like kind of late in the afternoon, the day before, but at most within 48 hours of their tube placement. And we put them through a whole like 2-hour battery of assessment. So we do behavioral audiometry, but we also do standard tympanometry. We do otoacoustic emissions, and we do a test called wideband tympanometry that I'll describe in a minute. And then I see them in pre-op the morning of surgery just to confirm. I repeat TIMPs and OAEs and wideband and confirm that their auditory status appears on any of those tests to not have changed. So everything looks consistent from what we saw in the lab. And then there are a few characteristics that the surgeon kind of characterizes when they are placing the tubes and kind of under the microscope. So they tell us how full the ear is, what the viscosity of the effusion was, and I'll talk a bit more about that in a minute. We also have some age-matched normal hearing control children who don't have any history or known history of otitis media within the last 12 months. And in these kiddos, we've ruled sensory neural hearing loss out at some point kind of in their test battery. Sometimes that's at the pre-op visit. Sometimes we wait and do it at the post-op visit, but these are all purely conductive hearing losses. So I'm going to assume, again, some general familiarity with behavioral audiometry and sort of the typical audiogram with standard tympanometry. But wideband tympanometry is something that you may not have heard of. So this is very similar to standard tympanometry and sort of how it's measured. You place a probe in the ear, you're playing a stimulus, you're looking sort of at sound transmission through the middle ear and or mobility of that eardrum. But what's really critically different about it is that we're using a wideband stimulus. So usually a click or sometimes a chirp stimulus. So we're playing a stimulus that goes from like 200 to 8,000 hertz instead of a pure tone. So standard tympanometry is typically done at 226 hertz. It's a very low frequency. And because it's only a low frequency tone, it's telling you really only about the stiffness characteristics of the auditory mechanics in the peripheral system. Whereas this wideband stimulus tells you about the stiffness characteristics, the mass characteristics, the resonance characteristics. So you get a much more comprehensive picture of the mechanics of what's happening in the periphery. These are tests that are FDA approved to be used in clinic. And there's lots of transformations we can look at. We can look at the impedance, the admittance, all sorts of things. But the one that's sort of been investigated most in the literature is something called absorbance, or previously called power reflectance. And basically that's looking at the ratio of how much sound did we play to what's reflected back and sort of then assuming what's absorbed. So if I play that stimulus, I know what I've played, and then I can measure what's reflected back, and whatever was reflected back is assumed to be absorbed by the system. And we look at that in a frequency dependence manner, and I'll show you some pictures of that. What's also kind of nice about this, we're not going to talk about a lot, is that you can do this in a pressurized state, like how we do tympanometry, but you can also just do it at ambient pressure. So you don't have to pressurize the ear canal. And there are some populations, particularly newborns, who have very compliant ear canals, where this can come in handy. And so there are several devices now that are FDA approved and used pretty regularly in clinic that you can make these wideband tympanometry measurements in. So these are just some pictures of them. The Interacoustics Titan system kind of had this technology first and sort of is the well-known device that does this, but the GSI TIMSTAR, which is another common admittance bridge used in clinics, now has this capability as well. So I think we're going to continue to see it as a more prevalent tool in clinic moving forward. Okay, so what have we learned from these studies so far about hearing loss in children with otitis media with effusion? So when we started this work, we did characterize those effusion characteristics, both just the surgeon sort of looking in the ear very carefully. Is there any air fluid line? Are there bubbles? How much fluid is in there? And we also were collecting the effusion or a sample of the effusion. You really can never suction the whole effusion out. But we would collect samples of them and get the actual viscosity and sort of quantify how much fluid we extracted at least. And so after we looked at all these different variables, we sent them out for bacterial assay as well to see if there's anything that would grow on the plates. But what we found is that of all the things that we looked at, really, there was little variability. So there was very few that were purulent. Nothing really grew. I guess that wasn't super surprising because most of these kids, by the time they get to ENT, have been on antibiotics 10 times over. And so not a lot of bacteria still was present in the samples that we had. When we looked at viscosity, these children had a diagnosis of OME in the clinic. Then there was some gap in time between when they had that diagnosis. We recruited them to the study and we actually saw them. And that went from somewhere between 5 and 57 days. And so when they had their tubes placed, 61% had fluid still in their ears, but actually 39% no longer had fluid in their ears at tube placements. We call those ears clear. So we can't really say anything about their effusion characteristics because they didn't have effusion. Of the 61% that still had fluid, the vast majority were mucoid at that point or highly viscous based on our sort of quantitative assessments. Very few were serous. And like I said, only one was purulent. So there just wasn't a lot of variability in viscosity, and it didn't really let us look at how that sort of lack of variability was impacting some of the audiometric outcomes we were interested in. But there was quite a bit of variability in the volume. So we saw, again, some of the ears were at this point clear of effusion, but many were either partially full, which means it could be quarter full, half full, 3/4 full. We basically lumped any sort of partial effusion together, or completely full, which meant that there was absolutely no evidence of air, no air bubble, no air fluid line. And so that's how we sort of grouped them. And that's what turned out to be sort of the most interesting variable, at least in terms of the hearing loss so far. So what we found is when we look at all these variables and we compare them to some of our audiometric outcomes, what seems to be really driving how much hearing loss these kids have is how much fluid is in that middle ear space. And it's not really about the absolute volume of the fluid, but how much fluid there is compared to the middle ear cavity. So really, if that ear is completely full and there's no air, that eardrum can't move and it really impacts sound transmission. And so these are kids we see with these moderate conductive hearing losses down here. So around that 40 dB across frequency. In contrast, if there's any air in the middle ear space, the hearing is quite resilient. Sound transmission is quite resilient. And so we see that those kids have kind of normal, borderline normal to near normal thresholds. As we are increasing our N in these studies, we are trying to see if there's some variability, like if there's more fluid, is the hearing loss more? But it's surprising how binary it really seems to be that, like, if there's any air, those thresholds just really pop up close to that normative line. And in fact, the ears that were completely clear of effusion, didn't have anything, heard similarly to the ears that were partially full, and that they were not statistically different. They still trend to be a little poorer if there's some fluid in there, but it's not a statistically significant effect. In contrast, though, they are on that kind of borderline normal thresholds. The age-matched controls all heard significantly better than either the clear or the partial ears. So though they are hearing normal, they're still not hearing as well as their sort of age-matched normative control kiddos. So if effusion volume, it tells us something about the hearing loss, we went to see if any of our sort of standard assessments can tell us something about effusion volume. So the first thing we looked at was tympanometry, because that's the most common assessment that kids get if they are having sort of a tube assessment or being assessed for OME. And when this is just an example of a child who had two very different effusions. So in the right ear, it was a partial effusion, and in the left ear, it was a full effusion, and their TIMPs look essentially identical. And we saw this repeatedly over and over. And so we don't see anything from the standard tympanometry measurements that seem to be able to predict how much fluid is in there. It often tells us there's something going on, there's some fluid in there, but it doesn't really do any sort of differentiation beyond that. In contrast, when we look at these wideband tracings, they give us a lot more information that seems to be telling us about what's happening to the mechanics and in turn sort of the characteristics of the fluid. So this is what the absorbance kind of graph looks like, and you're going to see a lot of these. And so on the x-axis is frequency. We're just going from, again, those low pitches to those high pitches, that 200 to 8,000 hertz, which is sort of the same range that we test hearing in. And then the absorbance goes from 0 to 1. So 0 means nothing was absorbed at that frequency, and 1 means everything was absorbed in at that frequency. And so we see usually a characteristic pattern that sort of looks like a mountain. And when we look at ears with otitis media with effusion, these are all the individual data. And so hopefully what this highlights is that there's tons of variability in these kids who have essentially the same diagnosis and otherwise the same presentation in terms of their mechanics. But when we separate these tracings and these groups out by how much fluid was determined to be in their ear, the effects are very kind of systematic and clear. So the ears that are completely full have a very sort of characteristic pattern where it's reduced across frequency with just this little hump around 4 kilohertz. The partial effusions have a slightly higher absorbance across frequency. The clear effusions have even higher absorbance across frequency. And then the normative controls have the best absorbance across frequency. Although they're pretty similar to the clear ears, there's just sort of this low to mid frequency reduction, probably because even though they're clear of effusion, they have some inflammation, maybe some sort of adhesions on the ossicles. We're not exactly sure what's driving that difference, but they're a little bit poorer than the normative control ears. So there's this very systematic effect on absorbance. So in that same kiddo that had the partial effusion on one side and the full effusion on the other, though their standard tympanometry looks identical, you can see below that the paired wideband tracings are very different visually. And it's quite easy to distinguish the difference in what's going on when we look at the wideband tracings. And so what we did is we tried to figure out whether we could train a machine learning algorithm to predict how much fluid was in the ear from these wideband tracings. So we took 70% of the data, we trained a model, and we said, this is a full ear, this is a partial ear, this is a clear ear, this is a normal ear, and then we threw in the remaining 30% and said, tell us, what the effusion volume is. And we obviously know from our surgical characterization. And this did a first kind of to look at whether just effusion was present or absent, so the full and partial ears versus the clear and normals, we have an incredibly high accuracy of 95%. This is much higher than kind of what's been reported in the literature for standard tympanometry of just saying if effusion is present or absent, which is usually around 80%, depends on the study. And then of interest, particularly to me as an audiologist, was could we distinguish the full ears from the partial ears, because these kids are hearing really differently. And so we were able to do that with this machine learning algorithm with an accuracy of 89% and a sensitivity and specificity of 89 and 88% respectively. So that still gives us a pretty high sensitivity and specificity to distinguish the full ears from the partial ears. And then when we look at distinguishing the clear ears from the normal ears, the accuracy is more moderate. Those are very similar in a lot of cases. It's pretty hard to distinguish that difference on an individual level because there's some individual variability in these tracings to begin with. But that's also maybe not the most clinically important question, because we already know if a child is coming in for an OME assessment that they're not in this normal condition. So really distinguishing those full and partial ears from each other was the clinical question for us. And this actually came in handy for me as a parent not too long ago. So I brought my son Grayson, and actually this is a couple years old now, he's 5, but in for my colleague's study, she was collecting some normative rotary chair data. And we were doing kind of a middle ear assessment to make sure that these kids were normal before we were running them on the rotary chair. And she ran him and he had flat tips and I had no idea. And I felt like such a bad mom audiologist. And I was like, I have to go run the wideband really quick. And so I ran upstairs with him and ran the wideband. And fortunately, if you can remember those tracings, these are pretty high for a kid with flat tips. And so even though he had flat tips and I knew something was going on, it suggests that he has more of a partial effusion going on, which means he's probably hearing okay, which is hopefully why I couldn't tell that anything was wrong. But it was funny that this just became directly applicable to my own life. So These data were pretty exciting to us because, again, we know that there's this wide range of hearing loss that can happen with otitis media with effusion. You can have these kind of big, moderate conductive hearing losses, and then you can have kids who come in that have pretty normal hearing. But also testing hearing in the age range where otitis media with effusion is most common is really challenging. And so if we could do a wideband tracing, which is as easy as making a standard tympanometry measurement, and look at the tracing and say, oh, that looks full, or that looks partial, or that looks clear, I think, well, we could then infer sort of, are they hearing okay? Are they not hearing okay? And that might be a helpful thing to consider as we are considering their management. And so we have tons of cases. I have to trim the cases down I share now, but I love looking at actual cases to just see how this sort of presents in different kids and in different years, and sort of compare our standard outcome metrics in the clinic to this wideband measurement and what it might add to the battery of tests we do. And so this was a kiddo who came in, so you can see their temp for the right ear here. And so it's got a wide gradient, a little bit reduced admittance. I think most audiologists would say, oh, that's kind of normal, but you see a lot of mobility still. Then we did OAEs on this child, and they were completely abolished. So no OAEs whatsoever, which is not uncommon with middle ear dysfunction. And when we ran the wideband tracing, we also saw very reduced wideband across the board, consistent with a pretty full effusion or potentially acute otitis media. We see sort of a characteristic pattern with acute otitis media, which we're still sort of digging into. But this child is likely hearing, with a moderate hearing loss. In contrast to the left ear, the temp still abnormal, but not all that different from the right ear. But you can see how different the hearing is. So beautiful OAEs across the board. And you can see the absorbance tracing is much higher. And you'll see two different tracings here. And so when we pressurize, we sweep pressure. And at one point, we match pressure between the ear canal and what's happening behind the eardrum. And that's usually where the eardrum's going to be maximally compliant or move the best. And so that's this red tracing, it's called tympanometric peak pressure. So we're matching the pressure on either side. The black tracing is just at ambient pressure. And so this child had negative pressure, which you can sort of see in the tympanogram. There's a little peak way out here to the left in kind of the negative pressure space. And so kind of in the ambient state, when we're not matching pressure artificially, there is some reduction in mobility of that eardrum from that negative pressure. It does not seem to be significantly impacting their hearing. And when we account for that pressure, there doesn't seem to be any additional fluid sort of causing things, whereas that right ear definitely has some fluid there. This was a kiddo one of our audiologists recently saw for sedated ABR, and the ENT actually looked in first and thought the ears were clear. They go to do the ABR, and they see quite a bit of hearing loss in that left ear. And so the audiologist said, I want to run a quick TIMP and a wideband. So she ran the TIMP, and again, you kind of look at the TIMP and you're like, oh, there's quite a bit of mobility there. Again, I would think this isn't super normal because of the gradient, but some audiologists would definitely consider this normal. But with that hearing loss, the audiologist who was doing the sedated ABR was still suspicious. And so she ran the wideband tracing, and it was very reduced across frequency, again, sort of similar to that full effusion or acute otitis media state. So she called the ENT back in, actually, and he looked back in and he said, I think you're right. I think there is fluid in there. And it did change sort of his interpretation of this case. He changed his note. And so it was nice to see how the wideband was able to, be helpful sort of in figuring out the potential etiology of this hearing loss. And this child ended up getting tubes placed, and that hearing did pop up after tube placement. And this was another kiddo that we have been monitoring longitudinally. And so we saw them at a few different visits. They were first seen in clinic, flat temps, pretty absent OAEs across the board. The one did pop up in that right ear, which we see sometimes with partial effusions. And these are the wideband tracings below. And so you can see that both look pretty full, sort of reduced across the board, though the right ear was a little bit better than the left ear, which might be why that one kind of OAE popped up. We went back a week later to see her, still very flat temps, but you can see this big improvement in the otoacoustic emissions. Sound transmission is definitely improving. We're not seeing evidence of that in tympanometry, but when we run the wideband, we see a big increase in absorbance. So we know the sound transmission is improving based on that as well. So you can see how the OAEs and the wideband are sort of telling you the same story there. And this last case was actually one of the first cases that we saw, I don't know, I think maybe 6 months after we started doing this study. And that really helped kind of change the course of this child's clinical care. So this was an older kiddo, an 8-year-old who was seen for suspected OM. I think he failed a school screening. he saw the audiology clinic flat temps and this bilateral conductive hearing loss. And then, he walked over to the otolaryngology clinic and he saw the ENT that works in my lab. And, he looked in and he was like, I don't think there's fluid in there. And one of my research audiologists was in clinic that day recruiting. He was like, Sarah, can the temps be wrong? And she was like, I mean, I don't like, he's like, I really don't think there's fluid. So he sent this child back to audiology and said, repeat the temps. They repeated the temps. They're still flat. And he's like, well, I don't really see fluid, but the temps are flat. The hearing loss is there. Like, let's schedule them for BMT. And fortunately, they enrolled in our study. And he actually said, I put the note he wrote from clinic that day, because he wrote on otologic exam, I thought the middle ear was aerated. So we repeated his temp flat again. He's had this hearing loss identified, and we discussed the common nature of fluid or dysfunction at this age. And so we recommended BMT. So he came into clinic a few weeks later, the night before his tubes placement surgery. We ran him through our whole battery. And, things were pretty consistent in terms of the audiogram. His temps were still pretty flat. But what was interesting is that for the amount of hearing loss he had, I would suspect him to be more of like a heavy partial, if you will, or closer to a full effusion. And when we saw a lot of OAEs present, particularly in his left ear, and then we looked at the absorbance tracings you see on the left here, the absorbance was much higher than I would predict based on what we had seen for a child with that much hearing loss. Like, things weren't just adding up. So we sort of had some pause about this because I was like, I don't think this kid has fluid. And that's when I went back and looked at the note and noticed that our ENT didn't think this kid had fluid. And so what we suspect actually now is that this child does not have a full effusion, but has obviously the absorbance, especially in this year, isn't quite normal. So there's still something going on, something causing that conductive hearing loss, but it looks a lot like otosclerosis in this case. So there's some stiffening going on. And I think it's more likely this child has a congenital fixation. We talked to the family. We decided to unblind the surgeon the morning of surgery, which we don't typically do, but I felt like in this case we needed to. And we talked to mom, and mom says that she's had 3 sets of tubes in her lifetime. She's never resolved her hearing loss, and that now they blame her hearing loss on like the scar tissue from the tube placements, essentially. And so the family ended up moving to Michigan, so it's a bit of an unfinished story, which was disappointing. But we did not proceed with tube placement that day, and at least the hearing loss and things seemed stable and not to fluctuate until they moved. So hopefully they're getting good care, and maybe again in Michigan. I wish I knew what happened to them. Okay, so most of my excitement, if you will, or interest in these wideband tracings rests on the idea that sort of testing audiologically these children with OME is challenging. And so we got some feedback when we submitted grants that that wasn't the case, and that you can get lots of, everyone knows how kids with OME are hearing, and, the audiograms are really complete. And so as an audiologist, I know that isn't the case, but we decided to go out and quantify it. And so what we found, and this is at our clinics at Boys Town, I'm a bit biased, but I think we have some really incredible audiologists, some of the best pediatric audiologists that I've ever encountered. When we look at a group of kids who were diagnosed with OME, in 20% of cases, we get absolutely no information in the booth. And then in an additional like 53%, we only get information in the sound field. And the downside to that is, though it may tell you if a child has sort of broad access to sound in at least one ear, which might be adequate for some speech and language development, we see a lot of cases where what's happening in one ear does not correlate with the other. And that's been published by others in the literature in kids with OM. So we see a lot of unilateral OME, but also a lot of asymmetric hearing. So you can have a partial effusion in one ear and a full effusion in the other. And so you might do pretty well on a sound field assessment in that case. But what's happening functionally, what that's doing to things like maybe your binaural hearing, or the things that, how to localize sound, things that really require listening with 2 ears, we don't really know. And so we're only getting ear-specific information on about 25% of kids. And even in the lab, where we have sort of every resource at our disposal, 2 testers in every scenario, we have all the time in the world, unlike when we're in clinic and we have sort of limited time, we still only get kind of a 4 frequency pure tone average in about 34% of ears. So even best case scenario, we are not getting kind of comprehensive hearing information on a good chunk of kids, particularly ear-specific information who have OME. But in contrast, when we do these wideband tympanometry measurements, we can get them in almost every kiddo. So it's pretty quick and easy. It's non-invasive. They don't have to behaviorally respond in any way. There's always one or two kids who will not let you go anywhere near their ears or screaming bloody murder the second you touch them, but they're pretty few and far between. And so we have quite a bit of success making these measurements. So in those 70+% of cases where you don't have ear-specific information about how they're hearing, you could run a wideband tracing and infer how they're hearing based on what that tracing looks like. And in fact, we're sort of trying to take the next step in this work by taking that variable of effusion volume out, though it really seems to be driving things. I'm sure viscosity is playing some little bit of a role. And so because these wideband measurements are a mechanical measurement of sound transmission, and these are primarily conductive hearing losses, which is sort of a mechanical hearing loss, we thought, well, maybe we don't really have to think about what variable it's telling us about. Could we just infer how much hearing loss there is from a mechanical measurement? And so as an initial pass at this, I took, you can see up on the right-hand side here, that red tracing, I took that whole tracing and I just averaged it into one number. I never in a million years thought this would work at all. I thought it'd be terrible, but I was like, quick and dirty first pass, let's see what happens. And I compared that with their average, in this case, air bone gap. So we had a group of kids where we had good masked bone conduction thresholds and pure tone air conduction thresholds that really tells us the true conductive component to their hearing. And so I looked at the average of that compared to the average absorbance across frequency. And what you see is the graph on the left there, and there's an incredibly strong relationship between that average absorbance and that average hearing loss. And so our goal was to sort of take this a step further. We're using a computational model, sort of a circuit model of ear canal and middle ear acoustics to try to see, can we predict how much hearing loss a child has. So basically take a wideband tracing and say, this suggests a 30 dB conductive hearing loss or something like that. And we have good preliminary data that strongly suggests that we'll be able to do that within what we consider a clinically meaningful sort of amount of variability. So within about 3 to 5 dBHL of their actual threshold. And so our hope is to develop a GUI interface that could be used with some of these types of equipment, where an audiologist could make one of these measurements, a tech, probably even in a pediatric clinic, an ENT clinic, run the tracing, and then the GUI would spit out, we think this is a full effusion, and that the estimated conductive hearing loss is 47 dBHL in this case, versus this is a partial effusion, and we think that the estimated conductive hearing loss is 12 dB. So that's a lot of what the current R01 we're working on is doing, is really increasing the N of this data set and trying to develop this machine learning algorithm and train the model. All right, how are we for time? We've still got about 15 minutes. Any questions on anything? I can sort of see the room. Keep plugging away. All right, so I just thought I'd share a few more case studies as you kind of maybe get familiar with looking at these tracings a bit for the first time. So in addition to doing this preoperatively prior to kids having tubes placed, we've also been recently, as part of this R01, monitoring kiddos very closely while they have active OME to look for kind of subtle changes in mechanics over time. There's not a lot of data out there to suggest, you know, if you see a child in clinic one day and then you see them, you know, 6 weeks later in the OR, what's happening between that time period? You know, is it stable? Does it fluctuate up and down? If it fluctuates, it does always progress towards normal. And so what we've been doing is we've been using a mobile van that we can do pretty much all the assessments I've described. So we can drive it to kids' house, have them hop into our not creepy anymore white van, because now it's finally wrapped. And we can run this quick battery assessments in like 20, 30 minutes max. And so we do this weekly with kids while they have active OME, and then we've been monitoring them for 12 months after the fact to sort of look for reoccurrence. And so these are some of the kiddos we've been monitoring, doing all of these different assessments in the lab. And then when they graduate from the protocol, we do a little graduation ceremony. So the kids actually really enjoy it and have been having a lot of fun with it. And so this is a kiddo that we saw on the initial visit, pretty abnormal flat tympanometry, but a few OAEs in both ears, which already suggests to me this is probably a partial effusion. And we saw wideband tracings in both ears that suggested a partial effusion. We went back about a week later, flat timps again. Actually, the OAEs were a little bit better. It's hard to tell them side by side, but there were more present in the right ear. And so the green tracings you see here are from the week before. The blue and red tracing are the left and right ear from the current week. And you can see the absorbance got a little bit better as well. So we see a little bit of an improvement in the OAEs, a little bit of improvement in the wideband. Again, the TIMPs aren't really telling us anything. So we thought, okay, this kiddo's on the way maybe to improvement. We're getting a little better. And so we went back a few weeks after that. And interestingly, this was the pre-op visit right before they were going to have surgery. And again, pretty flat abnormal TIMPs, but now the OAEs are completely abolished. So suggests to us that now the hearing's poor, and in turn, you can see the last kind of in green, the last wideband tracings, and then the current weeks, we see a big reduction in the wideband absorbance across frequency. And this child actually got acute otitis media right before surgery. And so that was just enough, kind of bordering on that partial to full line, and now it's a completely full effusion, and they aren't hearing well at all. This was another kiddo who was a little bit older, so we got better behavioral data from them. And so this is a good example of a big asymmetry between the ears. So right ear, flat TIMP, you see quite a bit of hearing loss in that right ear, and you see that reduced absorbance across frequency. The left ear, some negative pressure, but looks pretty normal, maybe a little bit of reduced hearing in the low frequencies because of that pressure, and the OAEs match everything too. So no OAEs in the right ear, lots of present OAEs in the left ear. We go back a week later, and really at this point, we're just monitoring that right ear because that was the ear with hearing loss. And so right TIMP still looks abnormal, but it does look better, improved from the week before. So you see the absorbance looks higher than the green tracing. You see the hearing is better, and now we have some OAEs present. So we went from probably a full effusion in that right ear to a partial effusion. And so the hearing's improved quite a bit. And then interestingly, we went back a week later and it went the other direction. So still flat TIMP, but now the OAEs are gone again, and the wideband tracing is reduced, and the hearing loss has come down. So not quite as bad as the first visit, but it does show that like you can go from poor to better to poor. And so it's not a linear fluctuation in a lot of these cases. So I just think those are some good examples of how much variability can be happening, but also how sensitive the wideband tracings seem to be and how they correlate really nicely with sort of subtle, small changes in hearing in both otoacoustic emissions and behavioral hearing. And so this is more, I don't know, I know, Reggie, you're recording this. I'm happy to share the slides if it's helpful for you guys. But this is just sort of a summary that I primarily share with audiologists when I share these data as like a quick and dirty way to think about how to interpret these if you come across them in your clinics. And so until we have that GUI that hopefully will be doing this for you, you know, if you have access in the clinic to a wideband system and you have a patient where it might be helpful, you could ask them to run the tracing and use this to sort of guide your interpretation. So you can see the gray and black plot there is what a normative ear looks like as compared to the pink, which is a full effusion, a partial effusion, and yellow, and then the clear ear in the teal. And so I think about this a lot like area under the curve. So the more area under the curve, the more air probably in the middle ear cavity, and the better their hearing. And so if you look primarily at that tympanometric peak pressure measurement, if you see both of them on the wideband printout, you know, if you look at that and think about how much space is there under the curve, there's not a lot of space. This is probably a child not hearing well. There's probably not a lot of air there. It's a full effusion as compared to, you know, a partial effusion where you're going to see more area under the curve. And the other thing you can kind of look at in these tracings is both sort of in research systems and in clinical systems. It'll spit out, in general, usually that TPP tracing, tympanometric peak pressure, as compared to the ambient or 0 decapascal tracing. And so if those are the same, then there's likely no air in the middle ear. If it is abnormal to kind of be causing negative pressure, or there's not much negative pressure there. Whereas in contrast, you see kind of on the bottom right here, there's a big difference between that TPP in red and that black tracing, which is the ambient, which suggests that if there is some stiffness, if there is some hearing loss, it's primarily driven by that negative pressure that's happening. We also have developed some sort of handouts that, again, primarily for audiologists to use, but these are in our ENT clinics because we are doing this as part of our clinical service in ENT. And so these are on a lot of the walls in our clinics. We have also developed some smart phrases that we've implemented in our Epic EMR system that can be sort of implemented just so you know what to put in your reports if you start using this for kind of pediatric middle ear dysfunction diagnosis. So some kind of general takeaways. Hopefully this has demonstrated that this tool, wideband tympanometry, has a lot of clinical utility and is feasible to obtain in clinical settings, even with these young infants and toddlers who have OME, and that it can be used to predict diffusion volume and hearing status in kids with OME, and also sort of monitor these fluctuations, which might help kind of in decisions about management. So if you're kind of doing a watch and wait approach, you could look at changes and track changes in wideband over time, and that might be informative. So just want to acknowledge all the people that contribute to this work. The top row, Sarah Alsleem, is a full-time research audiologist in the lab, and she is responsible for so much of this data collection and the day-to-day functioning of the lab. And then Rick Tempero is the ENT, who we could not do any of this work without because of his collaboration. We have two other audiologists that work in the lab part-time, so they're half clinic, half research, and that's been really valuable for our recruitment. And many research assistants throughout the years are funding, and lots of collaborators. And I do think we still have a little bit of time for questions if anyone has questions.
Awesome, Gabby, thanks. Any questions from the online or in-person audience?
It looks like the correlation between the wideband tympanometry absorbance. Sorry, can you hear me?
Yeah, I can. Sorry, I'm like leaning into here, but I can hear you.
All right. It looks like the absorbance measurements for the wideband tympanometry correlates really well for kind of extremes of good hearing and then pretty large bone air gaps. If I was understanding that one plot of yours correctly, but there weren't a lot of data points kind of in the middle. How do you think the wideband tympanometry performs for patients with maybe more subtle hearing loss?
Yeah.
Kind of.
So that's a great question. It's funny. So I'm not showing it here, but we just reran this analysis for another 100 kids that we've run between when we published these data and what we've been collecting for the R01. So it's a totally separate data set. And the good news is the correlation looks very similar. There's a little bit more variability, but it still has there's this gap sort of in the middle of that 20 to 35 dBHL. There's not a lot of dots. And what I think the reason for that is not that it's not sensitive to that, because the correlation's still really strong. It's that there is almost a binary here where if that ear is completely full of fluid and there's no air, they have that 40 dB moderate conductive hearing loss. If there's any air, even a little bit of air, suddenly the ear is very resilient. The eardrum has something to move, the ossicles can move, and you drop down to that 20, 25 dB conductive hearing loss. So it just seems that there's just not a lot of kids, because of maybe how the mechanics are working, that end up with sort of that, more mild hearing loss, if you will. It's either they're near normal or that full effusion state. And so I think I can actually probably pull up the plot, but we're seeing this even in a much larger data set. So I don't think it's just a sampling issue. I think it has to do with something about the mechanics. I will say this idea that volume is really driving hearing, and that any air sort of makes the transmission quite resilient, has been replicated. There's some animal work that is consistent with this and some temporal bone work. So it's not a totally novel concept. But yeah, really good observation.
Thank you.
Anyone else? You can also put some on the chat if you're online. I have a question, Gabby.
Yeah.
So, genetic mouse models wherein they clearly have smaller middle ear bullae, sometimes asymmetric or unilateral. Unfortunately, I am not aware of any study that measures the middle ear volume in children by age or sex.
Mm-hmm.
So do you think that your measurements of air versus fluid is enough surrogate for knowing how big the volume of the middle ear is in these kids?
I don't think I'd use that as a surrogate. I'd probably use a CT scan to try to estimate volume of the middle ear space. It's hard too, right? Because there's volume of that main cavity, but then you have the mastoid air cell space, and how that interacts in terms of the mechanics anyway, I think is a bit complex. But certainly the volume of air in that middle ear space is definitely going to impact hearing and kind of normal sound transmission. So in this case, like otitis media is impacting that. And it may be different in adults who have otitis media because they have larger ear canal or middle ear cavities. I think a lot about, obviously, an individual with Down syndrome, they have craniofacial differences in middle ear cavity volume. And I think those may be playing a role in addition to otitis media and things in their sort of normal sound transmission. So there's a lot potentially there. And I think Nate's on this call, but that's something Nate Green and I are actively talking about, trying to dig into more.
And that would be great. Normative values, I don't think they're available.
Yeah. But I think you could probably estimate them from CT scans.
Yeah, but I don't think anyone's doing it.
Yeah, that's true. I mean, you're.
So I hope somebody will. All right, anybody else have a question? We still have a few minutes.
Well, if you go out into the world of otolaryngology practice and you think this might be useful, please encourage your collaborating audiology providers to give it a try. And if at any point they or you have questions, we are always really happy to collaborate with clinics and such to help support implementation as much as we can. So.
Yeah, that's great. Let me know when you're back because I want to see your cushy van.
Yeah. Well, so we don't bring the van usually to Colorado. We have like a bigger RV that we bring on those trips, but it's really funny because everyone knows about me and my van. And so we just were in Boston doing data collection, and someone was like, saw a picture of it. They were like, wait, that's not your van. And I'm like, no, this is the RV. And they're like, how many of these rigs do you guys have? I'm like, I do a lot of remote testing. So we have a lot of fun remote testing abilities.
All right, if there are no more questions, thank you so much. Really
Yeah,
cool
thanks,
talk.
Reggie, for inviting me. Thank you all for your time.
Yeah, see you in June.